So our last speaker today is Dr. Julia T. Geyer from Weill Cornell Medicine, USA. She is going to give a talk on two topics. The first one is practical approach to the diagnosis of myelodysplastic syndrome, and the second one will be does thrombocytosis imply the patient has a myeloproliferative neoplasm and which one? So please welcome Dr. Geyer.
Thank you. Thank you very much. I'm very grateful to the organizing committee for inviting me. It's incredible to be here in Thailand. I've never been to Asia, so thank you. Okay, so I practice hematopathology and I sign out everything, but my main focus is in bone marrow pathology. So that's why I wanted to present two topics related to bone marrow pathology today. All right, so MDS, just a few slides to introduce the topic, is a clonal hematopoietic neoplasm. The patients have persistent unexplained cytopenias, they have morphologic dysplasia, and they have a risk of progression to acute leukemia. The cytopenias are typically long-standing, and the dysplasia, as we know, is significant if more than 10% of the cells are dysplastic. The proof of clonality is not required, but I think we all feel much more comfortable if it is there and if we find a mutation or a cytogenetic abnormality. A few other things, the dysplasia with the best specificity for MDS is found in the neutrophils and in megakaryocytes. The erythroid dysplasia is a little bit nonspecific and can be seen in reactive conditions. And the other thing which is very exciting in our field is we now have the thresholds to define cytopenia independently of where we practice and what our laboratory cutoffs are. So we have the cutoffs for anemia, for neutropenia, and for thrombocytopenia, which you can see here. So then I have to talk about this, which I think the previous speakers have kind of very tactfully avoided, which was great, but I have to discuss the little problem we have in HemPath and the two classifications. And the reason why I'm bringing this up is because in this particular topic of MDS, there is quite a bit of inconsistencies and controversies and discrepancies. So I'm going to take you through both just to kind of do an overview of what's going on with the two classifications. You see that the WHO changed the name to myelodysplastic neoplasm. The ICC still has the name of myelodysplastic syndrome. But the good thing is that the WHO is still abbreviating it to MDS. So in the end of the day, when we talk about it in English, we always say MDS. So it really doesn't matter which classification you're using. So just a quick overview of the WHO. Just like acute leukemias, MDS is divided into cases with defining genetic abnormalities up on top. Sorry, you cannot see the pointer. And then MDS, which are morphologically defined, that do not have these defining genetic abnormalities. The ICC divides it in a very similar way, but I'll go a little bit more slowly because I like the way ICC has done this. So the clonal cytopenia of undetermined significance these are the cases that do not have dysplasia. And then we move on to MDS with deletion 5q, and they are characterized by deletion 5q. So far so good. And then we move on to MDS with mutated SF3B1, and these are the cases which have SF3B1 mutation. Just notice that if you have something that you want to call clonal cytopenia of undetermined significance with SF3B1 mutation, this case automatically becomes MDS. And finally, we have this new category. Both WHO and the ICC have this new entity of MDS with mutated p53. Notice the blast cutoff is low for the entities on top and is higher for this entity on the bottom, which becomes significant. And the other thing is MDS with mutated p53 is a terrible disease, and so it basically trumps all the other entities that you have there. So if you find p53 multi-hit p53 in either one of these, you cannot call it. It becomes MDS with mutated p53. And then if there are no recurrent genetic abnormalities, then we move on to the MDS NOS, either without dysplasia. You can call this if we have some cytogenetic abnormalities listed up on top. Let's see if I can make this work. I have noticed that one of the previous speakers managed to get the pointer up, but I do not know how they did that, and kudos to them. They're more technologically advanced, so I apologize. I don't know how to do this. Thank you. Okay, wonderful. So you can get to MDS without dysplasia if you have abnormalities in chromosome 7 or a complex karyotype. And then something else to notice is there is only one category of MDS with excess blasts in ICC, and these are the blast cutoffs. And that's because they introduce a completely new category of something called MDS overlap with AML for cases that have more than 10% but less than 20% blasts in bone marrow and peripheral blood. So I'll just take you through the entities, and hopefully it will be relatively painless because some of this can be pretty dry. But the first entity to talk about is MDS with deletion 5q. I really like that the WHO says low blast in the name, because this is something to remind us that if you have increased blasts, you cannot have this entity. It is a very indolent entity, so it's something that has not really changed compared to the previous classification. And we all know that this is mostly a disease of the elderly, women with macrocytic anemia, and the bone marrow is going to be normal or hypocellular with some atypical megakaryocytes. The cytogenetics can have 5q deletion plus potentially one other abnormality, is just not chromosome 7. Chromosome 7 is very bad, so chromosome 7 will put it in a different category. And then we can also have some of these mutations. And the reason why we're being so strict with this definition is because when diagnosed correctly, it's a very good outcome MDS. So you don't want to contaminate this entity with potentially some more aggressive variants. And this is just a representative example. So you see that this bone marrow is either hypocellular or normocellular for this patient's age, and then there are numerous scattered megakaryocytes, and then on higher power, this is a very typical morphology, and you can really suspect this entity just by looking at the megakaryocytes. They have these round, monolobated, and kind of hyperchromatic nuclei. So how do we sign this out? I did want to make this practical. In real time, we can turn around a case like this in about 1 or 2 days. At the same time, we need to have cytogenetic and molecular results to make this diagnosis. So in our laboratory, cytogenetics takes about 1 week. We're not fortunate to have NGS. We send this out to a commercial laboratory. That takes about 2 to 3 weeks. So what we need to do is to sign out descriptively, and then look out for these results and put in an integrated diagnosis is an addendum. So what I would do is I would say something descriptive, normocellular bone marrow with atypical megakaryocyte, C note, and then in the note we need cytogenetics to confirm presence of deletion 5q. Only one additional abnormality is allowed. Monosomy 7 or deletion 7q are not allowed. So cytogenetics really is very crucial to make this diagnosis. At the same time, NGS is also necessary because if you have multi-hit p53, that takes it out of this category. So the next entity I'll mention is MDS with mutated SF3B1. And again, the WHO definition very helpfully reminds us this has to have low blasts. So less than 5% in bone marrow, less than 2% in blood. Now, WHO is going to say that if you have more than 15% ring seroblasts, it may substitute for SF3B1 mutation if it's not available. But the ICC is more strict, and it just basically says that cases with ring seroblasts but no mutations should be classified as MDS NOS, with the idea that it's the mutation that drives this entity, not the ring seroblasts. The ring seroblasts are helpful to suspect the presence of the mutation, but not the other way around. So the cytogenetics, again, should be very simple and non-threatening. We should not have abnormalities of chromosome 5 or 7 or 3, which is terrible, or complex karyotype. And as far as mutations, we need to have SF3B1, and we should not have p53 or UNCS1. And again, the reason for that is if we're very strict with this criteria, these patients do very well. It's a really good prognosis, MDS. So on bone marrow aspirate, if you look at those, I know many people don't outside of the US, but you are going to see ring seroblasts, which will make you suspect this entity. So how do we sign it out? It's the same idea. It's a descriptive diagnosis, normocellular bone marrow with presence of ring seroblasts, C note. And then in the note, we're going to say we have to correlate with cytogenetics and rule out all of these abnormalities. We have to wait for NGS. Now, depending on the oncologist, some of our leukemia oncologists, they send everything for NGS. Some of our hematologists will not send NGS at all. So if you don't know if there is a pending NGS or not, then I would put a note and say that you can submit peripheral blood for NGS analysis. And in the absence of the mutation, please consider these reactive causes of sideroblastic anemia. There are multiple benign reasons for someone to have ring seroblasts, and it is not equivalent to having MDS. So then we get to the final genetically defined subtype of MDS, and that's MDS with mutated p53. And thankfully, this was covered really nicely earlier today, so I'm not going to go into a lot of details, but I will just mention that you need sequencing fish arrays, karyotype. It's a pretty complex diagnosis to put together. One thing that is very useful, that we have found very useful and a lot of other labs are using, is immunohistochemistry for p53. So if you see strong nuclear staining in at least 2% of the cells, it correlates well with p53 mutation. The issue is just seeing the positive stain is not going to tell us if it's monoallelic or biallelic, as was mentioned before, so we still have to do the molecular testing. And then the definitions are very different. You can see that in the WHO, you need less than 20% blasts. In the ICC, it's going to be 9% or less. At the same time, the detection of more than 2 mutations or mutation and copy number loss is pretty similar. So I think these definitions, they're very complicated, but hopefully in the same classification we'll get on the same page about what we're calling multi-hit p53. Something that's really helpful is these are really bad cases. These patients have a bad disease. So the vast majority of patients are going to have a complex karyotype. So if you have your immunostain, and if you have dysplasia, and if you have a cytogenetics with complex karyotype, that's a pretty good sign that it may be this entity. Now the opposite is not true. Say you have someone with complex karyotype with p53 deletion, that does not mean that the patient has MDS with p53 mutation, because you still need to look at the mutations. So the ICC says that the VAF can be helpful as a presumptive evidence, but again, as we heard earlier, I think that is also problematic, so I don't know, it's very complicated. But the reason why we need to think about this entity is because these patients have a very poor prognosis. They're mostly refractory to therapy. They don't do very well even with bone marrow transplant and complete remission. So again, we have to be careful who we are putting into this category, because it's something that's very significant for this patient. So I have a few examples here to show you. This was a 62-year-old lady with worsening pancytopenia. You can see some really dysplastic megakaryocytes. Some are small, some have widely separate nuclear lobes. At the same time, there's some evidence of myeloid maturation, so no obvious increase in blasts. So with immunohistochemistry, CD34 is showing maybe a borderline increase in blasts with some abnormal clustering in areas. And then p53 here is highlighting a subset of the cells with a pretty strong staining. And on higher power, I think we can see that it's predominantly in the erythroid cells and maybe some megakaryocytes. This patient turned out to have a complex karyotype with loss of chromosome 17 and at the same time a p53 mutation, so this would fit into the multi-hit p53 alteration. This is another example of an 87-year-old gentleman with new pancytopenia. You can see again that the megakaryocytes are quite small and dysplastic, and there is a lot of erythropoiesis with some megaloblastoid changes, some erythroid left shift. CD34 is showing again this pretty abnormal pattern with maybe a slight increase in blasts, a little bit of clustering like over here, which we don't like to see. And then p53 has a pretty strong expression in cells that seem to be probably erythroid precursors. And this patient also turned out to have a complex karyotype and a p53 mutation with a very high variant allele frequency. So again, a good example of this entity. So just to point out what happens to patients who had the prior cytotoxic therapy, who had the previous cancer, or someone who maybe has a germline abnormality in p53. So the WHO and the ICC, very different approach, extremely confusing. The WHO has this completely new chapter that is called secondary myeloid neoplasm. And what they say is that if the patient has a history of prior cancer, that supersedes p53. We should make a diagnosis of myeloid neoplasm post-cytotoxic therapy. I think with the idea that the history of chemotherapy is so powerful that we don't care about p53 at this point. Now the ICC is telling us that we should keep the diagnosis MDS with mutated p53 and just add a qualifier. So MDS with mutated p53, therapy related, which to me personally makes more sense to do it this way. So how do we sign out these cases? Well, for MDS, this is the panel that we use at our institution. If we need to do stains, we will do CD34, CD117, MPO for myeloid precursors, CD61 for megakaryocytes, CD71 for erythroids, and I pretty much always do p53 because it's so useful. And then if it's positive, I will call it MDS and just say that it's overexpressed by immunohistochemistry, see note, and then in the note again we have to wait we have to wait for cytogenetics. Is there going to be a loss of P53? Is there a complex karyotype? That's really helpful if it's present. Await results of the sequencing. Is it the monobiallelic mutation? What's the VAF? So the ICC has this pretty arbitrary cutoffs for VAF, which I think are pretty controversial with a lot of people, but I imagine that they probably put them in just to have some kind of guidance for us. If it's a very low VAF, that it may not be significant. If it's 10%, then potentially it's something we have to pay attention to. And then there's some controversy. What is evidence of multi-hit state? There's some studies that say 23%, which is really hard to use as a number. But again, just something to keep an eye on as future research comes out. This is hopefully will become more clear. MDS NOS, or MDS with low blast. So these are cases that we all know and see. They have cytopenia, dysplasia. The WHO says the distinction between single lineage and multilineage dysplasia is optional, which I like, because I personally don't really see a point of saying it's just megakaryocytes or dysplasia. I mean, I don't know. I don't really talk about this in my reports. Detection of clonal abnormalities desirable, they say, but not required. Now, the ICC has 3 subtypes for this entity. They talk about MDS NOS without dysplasia, where you have monosomy 7, deletion 7q, or complex karyotype. If you don't have that, then they do recommend that you either that you mention if it's single lineage or multilineage, just like it was done in the past in the previous WHO editions. So then I just have to mention this new entity in the WHO, hypoplastic MDS. They define this as myeloneoplasm with significantly decreased age-adjusted cellularity as determined on a tree-fine biopsy, which is good news for us who look at core biopsies as opposed to aspirates. For example, it's relatively common according to the WHO. The patients are usually younger than those with MDS, but older than those with aplastic anemia. And then I think the point of this entity is to mention that it can be driven by a T cell mediated immunity on hematopoietic stem cells with expansion of CD8 positive T cells. So many times we will do immunostains, you will have an increase in T lymphocytes. If you do clonality testing, they may be oligoclonal or even clonal. That's definitely something that we see. And there is also overlap between paroxysmal nocturnal hemoglobinuria and aplastic anemia. I think it gets a little bit more confusing because, as we know, patients with germline mutations, they can have hypoplastic bone marrows at baseline, and they would be in this category as well because it's hypoplastic. But in this case, this is not immune mediated, it's a completely different mechanism. These are just the definitions for the bone marrow cellularity that should be used. And blast counts are variable. It does not meet criteria for MDS with defining abnormalities or MDS with increased blasts. This, I think, is very problematic because in my experience, we pick up these cases because we see increased blasts, not the other way around. If we don't see an increase in blasts, then it's difficult to make a diagnosis unless you have obvious dysplasia. Chromosomal abnormalities are not that common, relatively speaking, and there's a lower prevalence of mutations compared to other MDS types. And the prognosis is worse than aplastic anemia because it's a neoplasm, but potentially better than MDS. And some hematologists do treat these patients differently with immunosuppressive therapies. So here is an example that, in my opinion, is something typical of this entity. This would be a 62-year-old lady with pancytopenia. You see that it's a pretty hypocellular bone marrow. And then you have some erythroid aggregates, you have some megakaryocytes. There is no obvious increase in blasts, but it's always good to do stains on a case like this because we don't want to miss something bad. And when you do stain on this biopsy in particular, it did have an increase in CD34 positive blasts, which you can argue, is it less than 5% or is it more than 5%? I think it's a little bit more than 5%. And then P53 in this case was strongly positive. So the karyotype had deletion 13q, and the fish showed evidence of P53 deletion, and sequencing was never done. So how do you classify this case? According to the WHO, you will put this into the hypoplastic MDS. According to the ICC, you would definitely want to do NGS to rule out presence of multi-hit P53, which is a completely different entity. So I think this is just an interesting entity to keep track and to see how this evolves and if this survives into the new classification. So as far as MDS with increased blasts, we have to change the terminology. It's so confusing. So the ICC is excess blasts, the WHO is increased blasts, but I think the main point here is that the WHO has 2 categories, but the ICC only has 1. And this is the explanation that the members of the WHO have put together in their seminal paper in leukemia, and it's also in the actual book. So I'm going to read this. They say the pros and cons of merging MDS with increased blasts 2 with AML were explored in multidisciplinary expert discussions and at editorial board meetings. An arbitrary cutoff of 10% blasts to define AML carries a risk of overtreatment. And then they also mention that there is a broad agreement that MDS with increased blasts may be regarded as AML equivalent for therapeutic consideration and from a clinical trial design perspective. Here is the standpoint of the other group, the ICC. So they have mentioned that you make a diagnosis of MDS/AML for cases with more than 10% bone marrow blasts. And what they say is they did this to acknowledge the biologic continuum between MDS and AML, and the name MDS EB2 in adults with 10% or more blasts is changed to MDS/AML. Patients with MDS/AML should be eligible for both MDS and AML trials, which will facilitate optimizing the management of some patients. So you can see that there is a little gap that we have to bridge eventually at the next classification, and you can decide for yourself what makes more sense to you or what you agree with. But I think this is something that we grapple with both in pathology and in hematology, of course, as well. Our clinical colleagues have to deal with this every day in the clinic. So finally, there's just this MDS-AML with mutated P53, and this applies to patients with 10 to 19 bone marrow or peripheral blood blasts. And the only thing to remember is that this does not require a multi-hit P53. Any kind of P53 mutation will fit into this entity. So I just want to finish up with a few examples. Imagine that you have a 58-year-old woman with significant anemia with trilineage dysplasia, presence of 16% blasts, presence of 17p deletion detected by FISH, and P53 mutation. So biallelic abnormality of P53 and increased blasts. Based on the updated WHO 4th edition, this would be called MDS with excess blasts 2. Based on the WHO 5th edition, this will be called MDS with biallelic TP53 inactivation. And the ICC is going to say MDS/AML with mutated P53. Now imagine you have the same lady with the same anemia, dysplasia, 16% blasts, but the karyotype only has trisomy 8. So you have one hit P53 abnormality, not two. In this case, The WHO 4th edition, again, is going to put this into MDS excess blast 2. The 5th edition is going to similarly call this MDS with increased blast 2. And this is partially based on this study, but there's a bunch of studies, you can look them up. But it says that about 1/3 of MDS patients with increased blasts have monoallelic TP53 mutations, and their clinical outcomes do not appear to differ from those with wild-type P53. And then the ICC is going to say that this is MDS/AML with mutated P53, and based in part of this study, but there is many more stating that monoallelic mutated P53 AML has poor prognosis. By this logic, MDS/AML with monoallelic mutated P53 is also going to be allowed and have a poor prognosis. And then my last example, this is a 62-year-old man with anemia, 16% ring 0 blasts, no increase in blasts. The karyotype has trisomy 8 and SF3B1 mutation. How would you classify this patient? So based on the updated 4th edition, you would call this MDS with ring 0 blasts. Based on the 5th edition WHO, you will call this MDS with low blasts and SF3B1 mutation. And the ICC will call this very similarly MDS with mutated SF3B1 mutation, so basically in the same manner. And I'm going to finish up saying that we have great news. We're going to meet in Chicago, the ICC and the WHO and the unaffiliated pathologists. I'm hoping it will be peaceful and beautiful, and everyone will get along, and that we'll have a beautiful new classification for the 6th edition. So thank you very much.
Yeah.